Welcome everyone to tonight's webinar, Respiratory Medicine, a comprehensive update on interstitial lung disease, Legionella, and leptospirosis. We are joined tonight by presenters Dr. Elizabeth Veach, Dr. Louis Holmes, and Dr. Tim Senior. My name is Serena and I'm your RCGP representative for this evening. Before we get started, I would like to make acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders, past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined with us online this evening. I would like to formally introduce you to our presenters for this evening. Dr. Elizabeth is a respiratory and sleep medicine physician at Concord General Hospital and practices privately in Wahroonga. Her area of subspecialty interest is in interstitial lung disease. She chairs the ILD multidisciplinary meetings at both Concord Hospital and Macquarie University Hospital. Dr. Lewis is a respiratory and sleep physician working at Macquarie University Hospital. He completed the training at Concord, Liverpool, and Double hospitals. He is an investigator on several clinical trials running at Macquarie University Hospital. We are joined by Dr. Tim Senior, who is our facilitator for this webinar. Tim is a GP at the Royal Aboriginal Corporation in Southwest Sydney. He is a medical advisor to the RCGP in Aboriginal and Torres Strait Islander Health and is a clinical senior lecturer in general practice and Indigenous health at the University of Western Sydney. Welcome to our all speakers. I will now hand it over to Tim, who will go over the learning objectives.
Thank you very much. Good evening, everyone. I hope you're all keeping well. It's nice to be with you tonight. I'm coming to you from Dharawal country this evening. And these are our learning objectives for tonight, which is the educational speak way of saying what we hope to get out of the evening. So that by the end of this online CPD activity, we should all be able to outline the broad spectrum of interstitial lung disease and features which indicate a poor outcome, demonstrate familiarity with the current anti-fibrotic medications, identify what's meant by atypical pneumonia and why this is not a preferred term, and summarize common clinical features and management of classically atypical organisms causing pneumonia, particularly Legionella species and Leptospira. So I'll pass without delay on to Dr. Veach to start us off talking about interstitial lung disease. Thank you very much for joining us this evening.
Great. Thanks, everybody. It's lovely to join you. I'll just share my screen. Okay, so I hope you can all see my title screen, and I've called this The Road to Better Understanding because at the time that I trained in respiratory medicine, which was last millennia, in fact, we didn't know very much about interstitial lung diseases at all, but it's an area in which our understanding has greatly evolved over about the last 20 years. So just to refresh everyone's memory about what interstitial lung diseases are, they're disorders of the interstitium of the lung, which is the space between the epithelium of the alveolus and the endothelium of the pulmonary capillaries. And this area becomes expanded by inflammation or fibrosis or both. And I've put up two slides here. One is a slide of normal lung up the top, and you can see how the alveolar walls are really very, very fine. Whereas down the bottom, you can see a slide from a patient with idiopathic pulmonary fibrosis, where these walls are markedly expanded by fibrosis and an inflammatory infiltrate. And so I think when you look at slides like this, it's quite easy to see why patients with interstitial lung diseases have difficulties with breathing and with cough. So we haven't previously been very good at ILD, and I guess it's relevant to think about why that is. First and foremost, they're relatively uncommon conditions with a prevalence which is order of magnitude less than asthma and COPD. They're also, as a group of diseases, extremely complex. So there's over 200 causes of interstitial lung disease, but the cause remains unknown in the majority of cases. The clinical presentation is very variable. So patients might present with a fulminant lung infiltrate and respiratory failure, which can evolve over days to weeks, or it actually might be a condition which is detected unexpectedly on a CT scan done for another reason. The radiological patterns are quite diverse and non-specific, and our strategies to achieve a definite diagnosis are relatively limited. And even if we get a piece of lung tissue, which is the so-called gold standard, you can actually see the same pattern in a number of different ILDs. Added to this, before 20 years ago, we actually had no agreed framework to categorize these conditions, and we weren't even using the same language in different parts of the world. So the document which probably kicked off our progress in this area came out in around 2002. And in fact, I've actually foolishly put the update on that from 2013. But the initial document had a profound impact. It standardized our language. It allowed differentiation of ILD types based on clinical parameters, radiology, and pathology. And it provided a framework which was sufficiently rigorous to encourage the development of clinical trials. And the table on the schema on the right is actually how they suggest we think about all the various causes of ILD under these different umbrellas. But even though that's quite simple, it's still not necessarily easy to remember. And I think I always like to remember the common things. And so down the bottom in red, I've listed the common diseases or broad areas that I think it's worth your while perhaps having at the back of your mind if you see a patient like this. So radiology is hugely important, and by that I mean high resolution CT chest. X-rays are really not sensitive enough to detect early ILDs or to tease out the different patterns. And there are four main patterns which I've put up here. So you in the top right, you can have profuse micronodules. In the top left, in the bottom left, you can have areas of ground glass opacity, and those are the areas that appear whiter. The black areas on that scan are the normal areas. In the top right, you can see areas of consolidation, and in the bottom right, you can see areas of reticulation or fibrosis. And I've put some, but even if you can recognize the pattern, you can actually see that pattern caused by a number of different triggers. And some of these include things that are not even interstitial lung disease, such as cancers and pneumonias can give some of these appearances. So radiology is hugely important in allowing you to shorten from a list of 200 possible ILDs down to a much smaller and manageable list of possibilities. But even so, it doesn't get you all the way there. Some of the important features to notice radiologically are particularly whether there are clear signs of fibrosis. And that's really important because patients who have signs of fibrosis as opposed to inflammation, they have a poorer prognosis. And the two features of fibrosis are honeycombing and traction bronchiectasis. If you see those signs, there's unmistakably fibrosis. And honeycomb lung appears as these multiple little cystic-like structures, often in the lower lobes and peripherally. And traction bronchiectasis is where the bronchi are pulled wide open by the surrounding fibrotic lung so that you get these very dilated airways that you can see traveling out to the surface of the lung. Some additional features that help you decide what sort of an ILD this is are the geographic distribution of the changes, whether they're upper lobe or lower lobe predominant, and also whether they're subpleural or central in location. And then there's the presence of additional findings such as lymphadenopathy or pleural disease or pulmonary hypertension that can be quite helpful in helping you decide exactly what you're dealing with. So having said that we are better at looking at CTs, we're still sometimes left with, do we biopsy or don't we biopsy? And so this is a question we at times have to grapple with. In the past, we used to use bronchoscopy with transbronchial lung biopsy, but it achieves very small pieces of tissue and is rarely diagnostic, and actually, I'd say rarely done now. Surgery achieves a nice big bit of tissue and is very helpful, but it's sometimes too risky due to the age of the patient and their comorbidities, or it may be refused by the patient. More recently, and this is in about the last 5 years, we've started to do bronchoscopic lung cryobiopsies. And that's where, through bronchoscopy, a cryoprobe is passed into the lung to freeze the section of lung that you're going to biopsy. And by freezing that section of lung, it allows you to obtain a much bigger sample than you could obtain if you hadn't frozen the lung, by cutting down the bleeding that you might that the patient might experience. And bronchoscopic lung cryobiopsies are done in theatres under a general anaesthetic, but they're a day-only procedure, very well tolerated. You can see down the bottom that I've put the sort of sizes of biopsy you'll obtain. So transbronchial biopsies will only be 1 to 2 millimeters in diameter, which is not very much for the pathologist to go on. But if you do cryobiopsies, you can get pieces of tissue up to a centimeter in diameter, and of course, surgical lung biopsies gives you much bigger biopsy specimens again. And just to say that the probably the initial most pivotal trial which kicked off lung cryobiopsies was actually done here in Australia, and it's called the Cold Ice trial. And they had 65 patients who underwent a surgical lung biopsy. And during the surgery at the same sitting, cryobiopsies were taken. And ultimately, they found that there was 70% histological agreement between cryobiopsy and surgical lung biopsy. But if you then took the case to a multidisciplinary team meeting, you could get agreement up to 77% after reviewing the radiology and listening to the clinical story. And if it was a case where the pathologist had high confidence in the cryobiopsy features that they were seeing, agreement went up to 95%. So this is really the way we now seek to diagnose those cases of ILD that need a biopsy, would generally have a cryobiopsy. But ILD diagnosis is still quite difficult, and in recognition of these difficulties, the use of multidisciplinary team meetings in the diagnosis of ILD has been advocated by multiple international consensus statements. And these team meetings should include respiratory physicians, a rheumatologist or immunologist, a radiologist, and a pathologist. And in fact, MDT discussions are now so firmly embedded in the management of ILDs that Medicare requires that patient cases have been discussed at an MDT for prescribing some of the medications we now use. So, having given you a bit of background, I want to flick onto management. But in the first instance, I'd like to just have one slide to tell you about idiopathic pulmonary fibrosis, because it's probably the most common ILD, and it's certainly the most feared. And it's been the condition which has really sort of kicked off our management clinical trials. So some of you will have a patient with this. IPF is a progressive lung fibrosis occurring in the 60s and 70s for which there's no clear cause. It's male predominant and the majority are current or ex-smokers. And so we generally diagnose this by excluding other known causes of a similar appearance on a CT scan. And then if a patient has a typical CT scan, that would usually be accepted as diagnostic. However, about 25% of cases will have an atypical CT scan, and they may need a lung cryobiopsy to clarify that IPF is the diagnosis. And the reason I tell you it's most feared is that prior to effective anti-fibrotic therapy, the median survival was only 3 to 4 years from diagnosis. So what about the anti-fibrotic drugs? Well, since around 2010, there's been a massive explosion of research into ILD, and this was encouraged by the massive success of the pulmonary vasodilators in pulmonary hypertension treatment and aided by our increasing understanding of the molecular pathways driving fibrosis. So IPF has been the prime focus of ILD research as it's one of the most common and easily recognized ILDs, and as I stated, the most feared. Many drugs have been studied, but 2 drugs have ultimately proven to be effective in phase 3 trials, and these are now standard of care for the management of IPF. Those drugs are nintedanib, which goes under the trade name of Ofev, and pirfenidone, which was marketed under the trade name of Esbriet. Now, these drugs are not at all related to one another, but they both show about the same efficacy, and that is that they slow the rate of decline in the forced vital capacity, which is the lung measure we predominantly use, by around 50% over 1 year. So some of you might have a few patients on these drugs, so I'll just tell you a little bit about them. Both drugs require an authority prescription. Nintedanib or Ofev comes in 150 or 100 milligram doses. The usual starting dose is 150 milligrams BD, although if someone's very little, low weight, or if they've got some renal impairment, I will start at the 100 milligram BD dose. If the 150 BD dose produces unacceptable side effects, you then reduce to the 100 milligram BD dose. Both doses were used in the pivotal trials. The main side effects are gastrointestinal and particularly diarrhea, which is very frequent. Probably 2/3 of patients experience an alteration in bowel habit on this medication, and a large number of them need to dose reduce. Other GI side effects do occur, such as nausea, vomiting, cramping, abdominal pains, and anorexia, and I've seen marked weight loss on a number of occasions. It can cause abnormal liver function in 5%, and in fact, you need to monitor liver function when you initiate patients on these drugs, and you then subsequently continue to monitor that for the duration of treatment. Pirfenidone similarly comes in a low dose and a higher dose. The standard dose in the pivotal trials was 801 milligrams TDS, but you can reduce to 2 of the 267 milligram tablets TDS if there are unacceptable side effects. Again, side effects are mainly gastrointestinal, but in this situation, a little bit more nausea than diarrhea. The other thing about pirfenidone is it can cause a photosensitive skin rash, and so patients must be counseled to always wear a hat and use sunscreen every day. It has a slightly increased propensity to drug interactions as well. So, after a little while, a few clever people thought, well, if these drugs are good at slowing down idiopathic pulmonary fibrosis, what would happen if we gave these drugs to people who had interstitial lung diseases that look exactly the same on CT scan, but we think are due to another cause, such as an autoimmune disease or hypersensitivity pneumonia. And indeed, because we do know that fibrotic lung disease caused by those other conditions will also progress like IPF does. So the INVEIL trial was a trial of nintedanib, and it showed that it can certainly slow the rate of decline of FVC in patients who were treated with fibrotic ILDs for a number of different reasons, which I've listed there. Now, pirfenidone has been studied in some smaller trials, and the results are suggestive of benefit with it also, but primary endpoints were not met, largely due to methodological problems. So currently in Australia, nintedanib is the only drug available for patients who have what we call progressive pulmonary fibrosis for a reason other than IPF. And it's been available again on authority prescription since mid-2023. So I've talked a bit about fibrosis, and I haven't told you much about inflammatory ILDs. And that's probably because the evidence base is pretty weak. Most of the treatments in autoimmune ILD come from studies in scleroderma, and the initial high quality trial was called the Scleroderma Lung Study back in 2006, which showed that cyclophosphamide can slow FVC decline. And it took another 10 years before there was a second scleroderma lung study, and that showed that mycophenolate was non-inferior to cyclophosphamide. So mycophenolate is much more frequently used now. The evidence base is quite weak in hypersensitivity pneumonitis. So we're really, in a lot of other sort of more inflammatory lung diseases, we're extrapolating from the scleroderma lung studies and basically using case series, small case series and observational studies rather than double-blind, placebo-controlled randomized trial data. So sometimes we have lots of inflammation. On the left, you can see a case with ground glass opacity in the lungs, that hazy, whiter, sort of widespread appearance. And sometimes we have clear-cut fibrosis on the right with areas of honeycomb lung and traction bronchiectasis, and there's no suggestion on the scan that there's any inflammation. And so if you've got cases down either end of the spectrum, it's pretty easy to decide what to use. But at times we'll have the case which is in the middle. And this looks like ground glass opacity. Indeed, it is ground glass opacity. But then you can see in that yellow circle that there are some very dilated airways. So there's traction bronchiectasis there. So we know that this case has both inflammation and fibrosis. We know that because of the presence of the traction bronchiectasis. So sometimes we'll get cases that have features of both. And then we have to consider, well, should we treat them for inflammation or should we treat them for fibrosis? And we use things like their age, their gender, background history, and so forth to help us make that decision. And sometimes people will end up being treated with both sorts of medication. So can we diagnose ILDs earlier? Well, we can, but there will be pluses and minuses in this. And what we're talking about now are interstitial lung abnormalities. And these are incidental findings affecting 5% of any lung zone. And they're found on CTs that are done for another reason. Basically, they've been recognized in numerous large cohort studies. For example, the Framingham studies all those years ago found interstitial lung abnormalities. They're not uncommon, as you can see, say around 5% of cases, but they're not necessarily benign because about half will progress over 5 years. And on these scans, you can see these very subtle subpleural changes in scan A have become much more distinct and fibrotic looking several years later in scan B. So unfortunately, as I'm sure you've always found, if you do a CT scan, it not uncommonly begets the need to do another one. So in summary, I'd like to say we've made a lot of progress in the last 20 years. We have a clear classification for ILDs, and that's provided the basis of significant research efforts across this time. We have a better understanding of the molecular pathways involved. We now appreciate the benefits of multidisciplinary discussions for ILD diagnosis and management. We've developed some effective anti-fibrotic drugs, and these drugs have had a very positive impact on the survival of patients with IPF and ultimately also on the survival of patients with progressive pulmonary fibrosis. But we've still got other things we need to achieve. We need to become better at recognizing the environmental causes of ILD so we can delete ongoing exposures. We need to refine our understanding of the pathways involved. We clearly need a wider variety of anti-fibrotic and anti-inflammatory medications which have better tolerance profiles. We need better strategies to predict ILD behavior so that we can avoid giving treatment which is unnecessary. And we need better strategies for managing the large number of interstitial lung abnormalities at which we're going to increasingly find. And AI might help us in that. Thank you. I'll stop sharing there.
That's wonderful. Thank you very much. It's just before 8. We have got one question come through, which we've just got time to send you away. Any complications with the cryobiopsy?
Yes.
Cryobiopsy.
Cryobiopsy.
Yeah.
Like any lung biopsy, it can cause bleeding, but the advantage in this situation is that the patient's breathing is being controlled by the anaesthetist. They're there, and you're down there with your camera, and when you see a lot of blood coming up, you can dilate up a little balloon which occludes that bronchus, so that even if there is bleeding, it's not going to get to the rest of the lung. So the danger is, because the pulmonary circulation has low pressure, it's unlikely that you're going to bleed catastrophically. And the real risk is bleeding enough, though, to get into other parts of the lung and cause worsening respiratory failure. And you can prevent that by occluding that airway and waiting. And you can do a few other things. You can put more ice cold water down and things like that. So bleeding's one thing. Look, of course, when you biopsy the lung, if you're too close to the edge, you might end up with a pneumothorax. But they can see where they are during the procedure on II, and so they try to avoid that. So it's a well-tolerated procedure. Nearly everyone goes home that night.
Lovely. Thank you very much. Thank you very much for your presentation. It's real optimism about some potential agents for treating that, and that's great to hear about. So I shall pass on to Dr. Holmes now, who's going to tell us about atypical pneumonias. Thank you very much, Dr. Holmes.
Great. Thanks for having me tonight. Let's get my slides up. I think you should be able to see that.
Yep, perfect.
Right, great. So yeah, I got the brief to talk about Legionella and leptospirosis, and I thought that was interesting. One, because I've probably only been related peripherally to one case of leptospirosis in my life, and two, that we don't really consider leptospirosis as a sort of pulmonary infection or a cause of an atypical pneumonia. And then that got me sort of thinking that we should probably try to define what is an atypical pneumonia a bit better, and I thought we could go through that before talking about the two bugs. So look, atypical pneumonia is a historical, traditional term coined at a time when we only knew about Streptococcus pneumoniae and tuberculosis, essentially. Early reports defined it as a pneumonia that wasn't strep pneumoniae and didn't cause a lobar sort of pattern, so it was kind of unusual presentations. In the 1940s, primary atypical pneumonia syndrome was coined, which was, I mean, there's a good description there, characteristically gradual in onset, constitutional and respiratory symptoms, pulmonary changes that were more obvious on imaging than exam. They described a variable course of illness. Patients didn't have as many complications. They took longer to recover, but they did. And it was also noted that penicillin and Bactrim, which were the main antibiotics at the time, didn't work, and there was no microbiological evidence of pneumococcus. And then that's kind of what we were left with for about 50 years, and we started identifying different organisms. In the 40s, Mycoplasma, which was thought to be the main cause of this atypical pneumonia syndrome. And then we identified Legionella at an American Legion convention in the 70s. And then we've identified Chlamydia pneumoniae. And then we've identified more viruses and fungi. The problem with the term atypical pneumonia is that it's not specific to any one disease. And it implies a clinical syndrome which isn't really borne out with any evidence. At the moment, consensus groups are calling atypical pneumonia caused by an atypical organism, but different groups have different definitions of what an atypical organism is. So most groups like the American Infectious Diseases Association and BTS, British Thoracic Association, talk about Mycoplasma, Legionella, and Chlamydia pneumonia, plus or minus some other things. Viruses might be included, fungi might be included. And then you'll get radiology reports saying a pneumonia has atypical features. Well, it's unclear what that actually means. Atypical organisms themselves, as we know them, are actually not very uncommon. So this is Australian data of 885 patients who presented with pneumonia. Only 45% had an identified organism. And you can see that, Streptococcus pneumonia is 14%, Mycoplasmas a similar prevalence at 9%, viruses are 15%, and then the other pyogenic organisms, Haemophilus and Moraxella, have a similar prevalence to Legionella and Chlamydia, right? So they're not rare. There's significant overlap in the clinical features and radiological findings of patients with pneumonia caused by any organism, and there's no clinical or radiological sign or feature that will tell you that a person presenting with respiratory symptoms and an abnormal chest X-ray has Legionella or Mycoplasma or Streptococcus pneumoniae. And someone who has a protracted illness with a non-lobar pattern may equally have pneumococcal pneumonia. So it's not kind of useful to distinguish them apart. And as we're getting better at diagnosing things with rapid PCRs now, we're going to be able to detect the organisms earlier, and we're going to be a bit more specific with our diagnosis, I feel. So some authors have said we should just drop it. Some have said we should reserve the term atypical pneumonia for like a truly new, rare thing that's occurring, like when COVID happened in Wuhan, which I think is sensible. But I kind of think that the atypical pneumonia syndrome will come out of favor and isn't that useful in diagnosis and management. That's my rant. So onto the actual bugs. Legionella, aerobic, fastidious, gram-negative intracellular bacteria. Globally, so there's like more than 200 serogroups that can cause disease. The most prevalent globally is the Legionella pneumophila, serogroup 1. But in Australia and New Zealand, Long Beach eye is about 50 to 60% of cases. The exposures are overlap, but they are different. So the pneumophila lives in lakes, streams, and artificial water reservoirs, whereas the Long Beach eye invades into plant material and is found in soil and compost. So that's why we ask about that on a history when someone comes into pneumonia and in with a pneumonia. It's transmitted via inhalation of aerosols from the water or the soil. You need a high number of organisms to get infected, so there's no person-to-person transmission. I think there's been one case report ever. It takes about 2 to 10 days to get pneumonia after it. Most of the infections occur sporadically, but you do get outbreaks commonly. Usually when you have a contaminated water source supplying a place where there's lots of people, hospitals, hotels, cruise ships, and rainfall in the setting of a tropical cyclone can also increase the risk of infection. There is a peak in the end of summer and autumn for the Nemophila, and for the Long Beach eye, peaks in spring and summer when there's more gardening activity. Risk factors for getting this disease: older age. So this little graph on the right is data from the surveillance system for notifiable diseases. As you can see, most of the cases are sort of after 50, with most of them at 60 to 70 years old. More than 75% of patients are older than 50. Immunocompromised patients are at increased risk of catching this. Smoking is a risk factor, as is alcohol use and having chronic respiratory, cardiac, or kidney disease, and men are more likely to get it. Clinical manifestations, as with all sort of pneumonias, can be not specific for a particular organism, but they get fever, cough, and breathlessness. With radiology, that again is not specific. You can get lobar pneumonia from Legionella, which would look like Streptococcus, but you can also get pictures like this, which is hazy opacification from the mid zones to the bases bilaterally. That X-ray could also be pulmonary edema, could be inflammation, could be hemorrhage. Not specific, needs the clinical situation as well. Features of a presentation that make you more suspicious of someone having Legionella, apart from them gardening 2 days before or sitting in the hot tub, is having nausea, vomiting, and diarrhea. Hyponatremia has been reported, mildly elevated transaminases, CRP that's very high for how sick they look. If they don't respond to a beta-lactam, you are suspicious that it's Legionella or an atypical pneumonia. If there's an outbreak, then that's when you also consider it. And rarely it can cause extrapulmonary disease, which can be like everything. You can get a cellulitis, myocarditis, meningitis from it. And there's this other, in the setting of an outbreak, people can get just an influenza-like illness without a pneumonia, which is coined Pontiac fever. This is, so there's been lots of studies to try to identify different organisms causing pneumonia over the years without microbiological diagnosis. And this is just one of those from the European Respiratory Journal, a case series of 37 patients with pneumococcus and 32 with Legionella, just to illustrate sort of more the similarities between their presentations. So smokers are more likely to get Legionella. In this case series, they were younger than those that get pneumococcus. The clinical symptoms, so pneumococcal disease is meant to have more pleural involvement and pleurisy, pleuritis, compared to Legionella that you can see on the bottom there. More patients with pneumococcus were breathless. More patients with Legionella had joint and muscle pain. However, there was significant crossover between the symptoms. So at the time you see them, you can't tell if they have it or not. And radiologically, the only difference in the radiological features were that pneumococcal pneumonia was more likely to have an effusion. But you can get any sort of pattern on radiology with either of these organisms. You diagnose it. So traditionally, culture and urine antigen. So the urine antigen is useful because you can do it, pretty quickly, get a result in less than an hour. It's sensitive and specific. Limitations is it only detects Pneumophila serogroup 1, which, as I said, is sort of only 50% of the cases in Australia and New Zealand. Culture, you can culture it. It's harder to grow, so it's not as sensitive, but that is a specific test. Now the preferable test would be to get a PCR on a lower respiratory tract sample, so sputum or bronchoalveolar lavage. Takes only hours to get. The sensitivity is more than that of culture. It's very specific. And most places now are doing these multiplex PCRs on respiratory samples, and I think that's going to be the way we do it going forward. So the patients that get it are older and can be quite sick. So it has a high overall mortality of 4 to 18%. And it's important to get antibiotics into them early. The treatment of choice or the antibiotics of choice are a respiratory fluoroquinolone or a macrolide. And of those, it's levofloxacin and azithromycin, which are bactericidal, go into the lungs well and are active against all species of Legionella. They do get resistance to tetracyclines. The duration is the same as for any community-acquired pneumonia. If they're immunocompromised, you give them at least 14 days. Prevention, so smoking and alcohol reduction or cessation in patients that have the disease with those risk factors. And then there are ways that you can prevent it from spread with exposure. So you can wear an N95 mask when using soil products, washing your hands after gardening without touching your face specifically, and try to reduce aerosolation of compost and mulch by putting it lower to the ground. And you can wet the compost to stop it from aerosolizing and causing dust. All right, leptospirosis we'll do quickly. That's it there on the top right, this spiral-shaped spirochete of the genus Leptospira. It's got this question mark hook thing at the top. The disease goes by a number of names. Wales disease, named after the guy who initially found it. Swineherds, rice field, waterborne, cane cutter, swamp and mud fever. Gives you an idea of how you're going to get it. It's a zoonotic infection. The main reservoir is mammals, and of those, the major reservoir is rodents. It lives in their kidneys and is excreted in the urine. Rats get it either in urine or in the nest from early exposure. Humans get it from direct contact with the animal or the urine or the environment contaminated with the urine. It can live up to months in soil and fresh water, and areas of rainfall allows the soil to mix with fresh water and allows the infection to spread. So we get it via mostly an open wound, so a cut or abraded skin or mucous membranes or conjunctiva in contact with either urine of the infected animal or urine contaminated water or dirt. Rarely is transmission through bites. There's very rare human transmission, but it is reported through sex and breastfeeding. Historically, the main sort of risk exposure was occupational, so agricultural workers, abattoir workers, people who had contact with animals that were infected. But now there's more international tourism and there's more sort of action, adventure kind of recreation activities where people are exposed to fresh water, kayaking, rafting, swimming, that sort of thing, and thereby exposed to the bug. Other risk factors are environments with poor sanitation, urban overcrowding, poor waste disposal, and heavy rainfall. So sort of tropical regions, Southeast Asia, in sort of slums is where it's pretty prevalent. And from a patient side, walking barefoot and being in the water, essentially. There are usually sporadic, but there are outbreaks when there's a big rainfall in an endemic area, or there's been some reports of recreational events like triathlons in infected water. They all get infected. A lot of pictures on this slide, but it's the most widespread zoonosis worldwide, or it's bacterial. It lives in tropical and subtropical environments. It is endemic in Queensland, northeastern New South Wales, and New Zealand. You can see, I'll start from the left. So that's just the case notification numbers over the past 20 years. And you can see that it goes in this cyclical pattern consistent with outbreaks. The top line is Queensland, and then New South Wales is the blue. The age group that's affected, it's usually younger men. So from 20 to 40 who are out there doing these activities really and getting exposed. Cairns and North Queensland are the most areas with the most exposure. It's worse in summer when people are out and about doing this sort of stuff. And globally, other areas would be sort of tropical Vanuatu, New Caledonia, Thailand. Hawaii actually has a higher rate as well. And then New Zealand's at 2.8 per 100,000 cases per year. Australia overall is at 0.5. Queensland's at 2.1. It manifests essentially as an acute febrile nondescript illness. Most cases probably aren't even diagnosed or present to medical attention and are self-limited and mild. But then there are some that present, obviously. The way it's divided is into this anicteric or icteric illness. So when they're jaundiced, that sort of portends a really poor prognosis. When they're not, it's a different sort of entity. I think it's kind of a historical definition, but it probably just reflects the severity of the illness and how it involves different organs. But the anicteric phase illness starts about a week after exposure, lasts for a week. They get acute febrile bacteremia, fevers, rigors, myalgia, and headache. The myalgia is usually in the calves and the thighs. They can get gut symptoms with nausea, vomiting, and diarrhea. And about 30% have a cough. Doesn't necessarily mean they have pneumonia, though. They can also get arthralgia, bone pain, sore throat, and abdominal pain. The feared pulmonary complication is rapidly progressive pulmonary hemorrhage, which I'll explain in a bit. Examination findings. So the thing that gives it away is this conjunctival suffusion or hyperemia, which is erythema without pus, so not conjunctivitis, but just a suffusion, which apparently is rare for other infectious diseases. They get sort of muscle tenderness, as I said, splenomegaly, hepatomegaly, lymphadenitis, pharyngitis. They can have abnormal auscultatory findings on examination, and they can get a rash, which can be like any type of rash, not specific at all. In terms of the labs, there's often a rhabdomyolysis with elevated CK. The white cell count can be anything, not that useful. Some of them have pancytopenia. They do often have mildly elevated AST and ALT, and the urinalysis is remarkable for proteinuria, pyuria, microscopic hematuria, and granular casts. You can get an immune phase after the acute infection, which often manifests as aseptic meningitis. In the interest of time, I'll move on to the severe manifestation is this icteric leptospirosis. There's about 5 to 10% of symptomatic cases, which carries a mortality of 5 to 15%. Rapidly progressive multi-system illness with basically renal failure, jaundice, myocarditis, and a vasculitis kind of picture, which then manifests as pulmonary hemorrhage and acute respiratory distress, which causes hypoxia and is the cause of death, usually. They can get conjugated bilirubins up to over 1,000. Up to 50% of the patients with this presentation need dialysis for support, and they can get the pulmonary disease. The pulmonary manifestations, so hard to tease out in the literature. Variable reports of the prevalence of pulmonary involvement are reportedly 20 to 70%. But there was a recent case study of 157 patients in an outbreak in 2005, which had abnormal X-ray in only 5%. Despite breathlessness, cough, and hemoptysis in 24%. The X-ray changes are mostly from pulmonary edema, from the kidney failure, or from pulmonary hemorrhage. So, I mean, this is an X-ray on the top right, which shows bilateral mid and upper zone predominant consolidation with nodular infiltrates, which on CT show this ground glass area on the right, as well as patchy nodules, which was thought to be pulmonary hemorrhage. You need a higher index of suspicion to diagnose it in a patient who is young with an appropriate exposure. And then it's important to give empiric antibiotics when it's suspected due to limitations with diagnostic testing. The preferred test now is a PCR. The problem with that is that the organism isn't always in the bloodstream and isn't always in the urine. So it's in the blood in the first week and then in the urine more reliably after the first week. If you combine taking the urine and the blood for PCR, the sensitivity is 87 and the specificity is 97, although there are wide confidence intervals for that number. The blood culture, you need to organize a specific growth medium, and even then it takes weeks to grow, so it's not useful clinically. And serology you can use as well with acute and convalescent IgG and IgM, which was the historical sort of diagnostic tool. Treatment is with doxycycline or azithromycin. In mild disease, if they're severe, they get IV penicillin, cephalosporin, or IV doxycycline has also been used. The main thing, though, I think, is supportive care, often in intensive care unit, with dialysis, ventilation, management of thrombocytopenia and other problems. There has been used steroids and plasmapheresis, although there's not much evidence. There's not much evidence for prophylaxis either. It's more advice to just avoid exposures and be aware of symptoms. And animals can be vaccinated, but it's arduous and variably effective. My summary slide is if you've got someone with a pneumonia, what you think is a community-acquired pneumonia, check their oxygen, see if they're not hypoxic. Look out for red flags that might prompt hospital admission. Get an X-ray. If there's an X-ray infiltrate, I just call it a pneumonia until you work out what it is. So you'd get a culture or a PCR as soon as possible. Treat empirically. Current guidelines are penicillin and a tetracycline or macrolide. Review them after 24 to 48 hours, and if they don't improve, then escalate and look for typical exposures. And if they are present, then consider what organism might be involved. Thanks.
Thank you very much indeed. That was really good. And we have got some time for questions as well. So if you want to type your questions into the Q&A box, we shall do our best to answer those. And Dr. Veitch, if you want to join us too and turn your camera on. I think one of the things that came up in the learning outcomes that as people type in their questions, it's worth just asking some of the features that highlight poor prognosis or better prognosis in interstitial lung disease. Are there features that help us predict that?
Yeah, there are certainly features. I mean, to some extent, though, it's a little bit unsatisfactory because the best predictor of future disease behavior is how it's behaved up to the point that you meet the patient. So that's not really great. We can tell someone you're going to do badly if they've already done badly. We really need some better parameters. But so if I get referred a patient who's got a little bit of ILD found on a CT abdomen done for another reason, and they've got no respiratory symptoms, I mean, that person's probably going to may well do better, or at least be earlier in the course of their illness, such that there's going to be a longer time to watch it evolve. Whereas if I have a patient who comes to see me with an 18-month history of progressive breathlessness and already severe fibrotic interstitial lung disease, well, that person's in trouble. They've got a disease which is progressing more rapidly now, and they're going to do poorly. And so extent of disease when you meet them, and that feeds into how they present, certainly poor prognostic features. More fibrotic looking, more like an IPF, they're going to do worse. The autoimmune related ILDs, just to say that in scleroderma, rheumatoid arthritis, lupus, etc. I mean, if you go hunting for these things, they're very common, but often they don't progress, but they can.
Brilliant, thank you. People are mainly putting appreciative comments into the question box, which is fantastic. I think people have really appreciated what you have to say. It certainly feels very topical at the moment because we've certainly myself, I suspect all the GPs in the audience are faced with lots of respiratory illness at the moment caused by all sorts of circulating infectious diseases. Do we have any evidence yet about whether COVID has long-term implications for lung diseases, or sort of interstitial or otherwise?
Yeah, I mean, I think COVID certainly can look. What we believe is that mostly COVID can cause an organizing pneumonia sort of picture that may get better with steroids, or possibly if you didn't give steroids, might still get better. I wouldn't like to say that you can't end up with permanent lung scarring. You can end up with permanent lung scarring from any pulmonary infection, but it seems to cause mainly an organizing pneumonia type picture, and often that does improve significantly over time. But we've had patients, especially in the first wave of COVID, who ended up being respiratory cripples. And
Yeah.
once you have substantial lung fibrosis, sometimes you've flicked a switch and you're going to get more fibrosis.
Yeah. Thank you. We've got a few questions coming now. I think one of them I think I saw in one of your slides, but is bronchoscopic cryobiopsy more specific or more sensitive than other methods in the diagnosis of interstitial lung disease?
The other biopsy methods, or I presume you mean not doing a biopsy. I mean, it's certainly certainly an open lung biopsy, which would normally be done thoracoscopically, by achieving bigger piece of tissue, is going to be more sensitive and more specific, most likely, but particularly more sensitive. The problem is that ILDs predominantly occur in older people. They're often very comorbid as well, and so it's not always feasible. So we think that for a lot of ILDs, we can make the diagnosis without a lung biopsy. Yeah, but there's still, I think it's fair to say that in a sense, there still isn't a gold standard for for a specific ILD diagnosis, because as I said, even if you get a good chunk of tissue, you may see the same pathology in idiopathic pulmonary fibrosis, or in rheumatoid lung, or in drug-induced lung disease, or in hypersensitivity pneumonia. So even pathology isn't fully specific for one particular sort of ILD.
Yeah, lovely. And final question, just before we finish, how can I differentiate ILD progression or infection by chest imaging? And I would imagine a lot of that depends on the context of the history and examination and the course of the illness that you've seen in requesting the imaging.
Yeah, absolutely. I mean, some of medicine comes down to simple stuff like, is there a fever? Is there a leukocytosis? Is the CRP up? Does the patient have infective symptoms? But it is at times difficult to dissect out. I think you have to go back to those sort of basic questions to ask yourself. But just looking at the CT scan of someone with ILD, if the scan gets worse or they get a chest infection, I can't tell the difference necessarily based on that scan alone. I have to go back to the patient and I have to ask them about their symptoms, and I have to look at those basic bloods.
Lovely, thank you. So we're just coming up to 8:30 now. So thank you very much. I think we all really appreciated what you had to teach us this evening. I shall pass back to Serena, and I think as people leave, they'll be left with the evaluation survey.
Thanks, Tim. I would like to extend my thanks to Elizabeth and Louis and Tim for presenting this evening. Also to everyone who has joined us online. We hope you enjoy the session and you also enjoy the rest of your evening. A friendly reminder that this is a CPD accredited activity, and to receive your CPD hours, you must complete the survey following this webinar. The session is recorded, so if you have missed any parts of the webinar, the recording will be available on the RCGP website within the next week. That brings us to the end of the session. Thank you and good night, everyone.